Good morning, everyone. Now we'll begin with our next session. I'd like to invite Dr. Vasadikar Madam and Dr. Devidas Dahifale sir and Dr. Prasanna Mishri-Kotkar sir as moderators for this session. Thank you, sir. Thank you, ma'am. Now I'd like to invite Dr. Varsha Rote Kaginalkar ma'am to present on radioanatomy of chest wall, axilla and breast.
So, morning everyone. It must be very difficult to attend the first lecture on Sunday morning after a very overwhelming last evening. So it was really a treat for eyes and soul. So hats off to all the performers and everyone who were there. Second thing, I was attending last few posters. So I would like to have some advice to the scientific committee. So since this is the first conference and we had very short time to prepare everything, so all the notices and instructions were not passed on to the students properly, and there was a lot of confusion. So maybe from next year we will be able to do the paper session nicely. So very good morning the chairpersons and everyone present in front of me. Next few minutes we will run through the breast anatomy quickly. Breast, it looks very simple, but it's not so. It's very hard to image or give the diagnosis, and it has a very long learning curve. Anyway, let's start with the first slide, that is development of the breast. Breast is a modified sweat gland. It lies between second to sixth rib, and its development precedes the menarche, and it develops from the mammary ridge. There are two ridges, and failure to involute the mammary ridges may give accessory breast development and accessory nipples. So the breast bud develops around 6 weeks, and the nipple areola starts developing around say 8 to 10 weeks. There are normal to have asymmetric breasts, and which is because of the differential response of the fibroglandular tissue to the hormonal environment. So this is a case. She came to us for right breast evaluation, and surprisingly I have never seen such a big fully developed breast in the axilla. So we evaluated all three breasts. This is the accessory breast having some calcifications in it, and this is the right breast for what she had come for, and it had beyond doubt she had carcinoma in the right breast, and we evaluated for these microcalcifications, which we did stereotactic biopsy, and which also came to be non-mass lesion carcinoma. So anatomy goes from skin, parenchyma and adipose tissue. Parenchyma, we all know it is a fibroglandular tissue. Skin, it has to be uniform, not more than 2 millimeters. Areola, we all know pigmented, Morgagni's tubercles are there, and secretions from these sebaceous glands which are present in the areola will keep the nipple moist and avoid it from the cracking. So this is the thickened skin over here, and this is the normal skin. The nipple, it is designed for nursing, and 6 to 20 lactiferous ducts, they open on its surface. Skin of the nipple is continuous with the ductal epithelium, and sometimes you might get nipple involvement in the carcinoma, which also known as Paget's disease of the breast or nipple. Yes, accessory nipples can be seen anywhere along the mammary ridges, and basically it should not be mistaken for any nevus on the skin. So we had a case which has a small nevus on the breast, but it took quite a while for us to rule it out as accessory nipple. Now coming to parenchyma, it is fibro and glandular. So fibrous tissue, apart from glandular, it has fibrous and some sort of connective tissue. And this fibrous and connective tissue, they form the supporting network which holds the breast structures together. I would say skin is the basic and the most important supporting structure which holds the breast against the chest wall. We all know there are fibrous septi going through the breast parenchyma from skin to deep fascia. We call it as from superficial fascia to deep fascia, and these are the septi, it's planar sheets kind of things, and these are the suspensory ligaments, and we call very commonly known as Cooper's ligaments. You can see here, I'll show it diagrammatically. There are certain spikes you can see over here. These are Cooper's ligaments attaching to the skin surface or under the skin, which are known as retinaculi cutis. Why it is important? Because these retinaculi cutis are accompanied by ducts, and sometimes, very rarely maybe, it harbors, whenever duct is there, ductal epithelium is there, and there is potential risk of having carcinoma over there. So even if you perform a mastectomy, skin sparing mastectomy, still patient gets recurrence because of this. Connective tissue, very interesting facts about connective tissue is breast has two types of connecting tissue. One is non-specified loosely arranged connective tissue which is seen all over in the breast parenchyma, and it is seen in between the lobules, interlobular, which majorly has the supporting function. Second thing is intralobular connecting tissue, which is this. So this is a special type of connecting tissue which harbors the very important unit of breast structure, that is TDLU, that is terminal duct lobular unit. And the lesions, majority lesions, regardless of benign or malignant, they occur in this intralobular parenchyma and this TDLU unit. So the lesions occurring in this intralobular parenchyma are fibroadenomas, very commonly we see cysts, phylloids, lobular carcinomas since it contains the lobule, and for the interlobular, that means this outer parenchyma, it sometimes harbor the sarcomas. Fascia, of course, we don't image on the skin, but it's nice to know what the fascia is and how it develops, because sometimes surgeon might find this fascia while operating the breast. So breast, it is supposed to, it is thought that there are two theories. The fascia splits into two and then breast develops like this, which is not supported by many, and this theory is supported by many people, and breast juts into that fascia, and the fascia covers it, and this layer becomes the deep fascia. So this fascia lies over this prepectoral fascia, which is very, very thin. Sometimes the surgeon might found while operating, sometimes he may not or she may not find it. So these fascia, they are loosely attached, and it promotes the movement of the breast over the chest wall, and the blood vessels and lymphatics, they freely cross over, and that's how the spread to the pectoralis muscle occurs. So, the glandular parenchyma, it's a proliferated ductal system, and the full differentiation of this ductal system occurs at after the first full term pregnancy, and this differentiation protects the women from carcinoma, risk of carcinoma. So this is a very, very important slide. Usually breast contain segments like this, 15 to 20 segments. Each segment has a lactiferous duct, which gets little bit, it has a dilated terminal sinus, which is lactiferous sinus, and each duct is a culmination of arborizing structures. This duct is a culmination of these arborizing ducts from the lobules, and this branching continues till it ends up into the blind pouches, which are known as, these are pouches like finger in the, the glove finger or something, if you poke your finger into the balloon, so how it shapes it, those are like that. And each region is known as acinus. This is one acinus, and which are the blind ends, and this group of acinus is known as lobule. It has the internal duct, and this is extralobular duct, which is entering into the lobule. Why I am so keen on showing all this? Because all cancers, they harbor in this region, and this specialized connective tissue around it. So this is the TDLU. If you forget rest everything, it's acceptable. Please don't forget this particular anatomy. So TDLU is the most important structure. It is the basic milk producing unit, and most cancer as well as benign lesions, they harbor, arise in here. So in summary of this breast, so far, breasts are composed of lobes, lobes are composed of lobules, lobules are composed of alveola, and alveola contain the ducts. And finally the ducts. This is the very familiar picture. Every one of you are doing breast ultrasound. Normal subareolar ductal system, and this on this mammogram you can see the dilated ducts over here. It was a patient of ductal ectasia, and and you can see the dilated ducts very nicely. So here histologically you can see inner layer, the epithelial layer where the cancer harbors, and outer layer where very thin myoepithelial cells are there, so they help in expressing the milk, and sometimes they form the neoplasm like papillomas. I won't go into the list. These are the lesions that occur in the ductal system and connective tissue. Coming to the adipose tissue, fat, subcutaneous fat layer, and the retromemory fat. The fat is the most ubiquitous thing in breast. It will be found in everywhere in the breast, and the breast parenchyma is distributed between the fat. And the cancers are seen at the junction of fat and commonly fat and FGP, that is fibroglandular tissue junction. And the subcutaneous fat may contain ductal epithelium. As I told, the ducts accompany the reticularia cutis. Nerve supply and blood supply. Nerve supply is from axillary artery and internal mammary, intercostal arteries. I'll just quickly run through. And sensory breast innervation is from intercostal nerves and lateral cutaneous, which is also these are also branches of intercostal nerves. So lymphatic drainage we see little in detail in axilla. Now I just run through. Lymphatic drainage of axilla, maximum lymphatic drainage goes to axillary lymph nodes and then to internal mammary and intramammary. Yes, this is something very interesting, that literature says only 5% women, they have intramammary lymph nodes, but at times they pose difficulty in diagnosis whether it is mass or lymph node. And nowadays in my day-to-day practice, I am seeing lot of intramammary lymph nodes everywhere in the breast, not only just the outer and upper quadrants. So this is the mammographic appearance of the breast, and we take MLO and CC view. Why MLO? MLO is because the breast is, the axis of the breast is oblique and it is along the free edge of the pectoralis major muscle, and it wraps around the pectoralis major. So it is very easy to pull the breast in that direction and scan it maximum amount of tissue and with less pain to the patient. Okay, what is the acceptability of the images? The pectoralis major has to be symmetric bilaterally. And if we draw a line from nipple to pectoralis, the end of pectoralis, it should make more or less 90 degree of angle, and the nipple should be seen in profile. So as I told, two standard views, but if needed, we can go for dead lateral rolled over views or cleavage views or spot mags or अजून कुठला व्ह्यू असतो एक spot magnification and rollover. I forgot one more view is there. Okay. So this is the CC view. It should be all breast. One very interesting fact about breast is it is amazingly symmetric. So when you compare the symmetry and if you see some asymmetry, that's the pathology majority of the times, and you evaluate the pathology accordingly. So this is how the CC view should look like. And the fibroglandular tissue is triangular in shape with the apex directing towards the nipple, and the shape and density is extremely variable depending upon the individual, and the blood vessels are better seen on the fatty breast. So these are 4 breast types which we report in our routine mammograms: fatty, fibrofatty, heterogeneously dense, and very dense, like extremely dense breast, type D breast. Yes. So when you have this CC and MLO view, sometimes you might see the pectoralis minor right in the upper corner of the scan, and sometimes you on CC view you might get something like this. So it's always better to be suspicious, but here it is a sternalis muscle, it is medial, and we checked it what it is. So this is a known fact. Sometimes when you pull the breast and if the scan is the technician is very good at the scans, taking the scans, so she might take this sternalis. If you get such type of density, you must investigate for the mass lesion, or if you get it little medially, centrally, or outer region, so it could be instead of sternalis, it could be pectoralis. So coming to ultrasound, skin, subcutaneous tissue, the mixed fibroglandular tissue, pectoralis major, and the chest wall. So while reporting, I would need some time. Okay, is it possible? Just 5 minutes. Fibroglandular tissue while reporting, so majority of you are doing ultrasonography. So while reporting ultrasound, breast ultrasound, you must have 3 types of fibroglandular tissue. One is homogeneous fat, which look like this. Homogeneous fibroglandular, which looks like this. It is a homogeneous fibroglandular tissue. This is homogeneous fatty, and this is homogeneous mix or heterogeneous, which is at times cause little difficulty in finding the pathology, and patients may be subjected to unnecessary biopsies, but we can't help. If you are not able to find it out, is it a fat globule or a pathology, you will have to go for biopsy. This is the case which this mass looks exactly like the fat distributed in the parenchyma. It was a fibroadenoma, and sometimes the Doppler comes to your help, which looks exactly like the fat, and the mass shows the vascularity. MRI is a problem solving tool in breast, and it shows very nice relationship of skin fat and the chest wall. The fibroglandular tissue is seen either intermediate or dark, depending upon the sequences. Yes, the contrast is very, very important. Unless we give contrast, see, MRI sensitivity is extremely high, which is 98%. But it is, the specificity is surprisingly very low. You can't say what it is. You can see the thing, but you are not able to diagnose what it is. So contrast is given. See how subtle the lesion is. This is called dot enhancement, which was DCIS. So another couple of minutes. Chest wall. Chest wall is very important structure while you are scanning the breast. This is the breast parenchyma and the chest wall, which is made up of serratus anterior, pectoralis major and serratus anterior behind. Pectoralis minor is not seen over here, and the corresponding CT image, pectoralis major, minor, serratus anterior would go like this, and the intercostal muscles, these are intercostal muscles, and the pleura behind. So the lesions of chest walls are envisioned by the cancers, most commonly breast cancer, and most commonly the breast cancer, foreign bodies, injuries, infection and inflammation. So this is how we scan pectoralis major, minor, serratus anterior and the chest wall, and we are going towards axilla. It is forming the axilla over here. So this is a case. The patient came to us with a breast swelling. We could feel palpate the breast swelling, but we were not able to find it out what it is, because mammogram was normal. So it was extremely medial side. So we took the cleavage view, nothing was seen, and then patient was subjected to MRI, and it was a cold abscess sitting over there. So coming to axilla, axilla is the most common, it is most commonly viewed on ultrasound. Every one of us are doing the ultrasound of axilla, and we do view it on CT and MRI as well. See, anatomically there are so many boundaries and walls for the axilla, but imaging wise these are the important, and which we can see basically. Anterior, posterior and medial, which is the chest wall, which is formed by serratus anterior, posteriorly subscapularis, and anteriorly pectoralis major and minor. Contents, we all know axillary vessels, brachial plexus, nerves and lymph nodes. For us, for now, lymph node visualization in axilla is important. You must be remembering this Chaurasia image, which we all have gone through in our first year days. So this is pectoralis major, this is serratus anterior, and part of humerus is head of humerus is seen, and this is the axilla. Same thing is being shown over here. Axillary contents, the pectoralis major minor, and this is axilla, pectoralis major minor, subscap and serratus anterior, and this is axilla. So this is how we scan pectoralis major minor and serratus anterior. It is going towards the humerus. How beautifully it is seen, and this is commencement of axilla. Just little further, major, minor, the contents, subscap, and below latissimus dorsi also comes, and this is the axilla. And these are the small brachial plexus, the nerves, radial, ulnar, and everything, and the lymph node is seen here nicely. Sorry. I think I have put these slides for the lymph nodes under the pectoralis minor. These are level 2, and if we go further, that will be level 3 lymph nodes, which are up and above the pectoralis major. So level 1, level 2, level 3, which is divided by pectoralis minor, lateral to pectoralis minor, level 1, under the pectoralis minor, level 2, and beyond, further medial and up is superior is pectoralis to pectoralis minor is level 3. Whatever lymph nodes we are seeing very easily, when you put the transducer and you see, those are all level 1 level 1 lymph nodes, and when you see them on mammogram, that is also level 1 lymph nodes. So these are examples of level 1 and 2. This is pectoralis major, minor. These are normal lymph nodes which are level 2 or 3, and these are level 1 lymph nodes. This is the axilla. Yeah. And these are the lymph nodes. Important thing is, how do you differentiate between the reactionary or hyperplastic lymph node from the malignant lymph node. The reactionary or hyperplastic or hyperplasia is the histopathological term. We call it as inflammatory or hyperplastic lymph node, which is uniformly thick, and it has increased central or hilar vascularity. In opposite to this, in malignancy, those are globular. Focal thickening is there, and you see intrasubstance peripheral as well as the hilar vascularity. So I'm so sorry, there were so many things. So as Dr. Rajesh yesterday told very specifically that radiologists are pattern readers. Yes, we are pattern readers, but we must understand what is the underlying process which is giving these patterns, which we see as images. And it is very, very important to know, to be a very good image analyzer or a radiologist, you must know the anatomy, physiology and pathology first. And I would say, if we read all these things, or if you are well versed with these basic things, you need not read radiology at all. So basics have no alternative. Thank you so much.
Now I'd like to request Dr. Vasadikar ma'am to felicitate Dr. Varsha ma'am.